Hello, everyone, and welcome to the Future of Nursing 2020-2030, Charting a Path to Achieve Health Equity, our final webinar in our webinar series. This webinar is entitled Diversifying the Nursing Workforce to Advance Health Equity, and my name is Ashley Darcy Mahoney. I am the Associate Professor at George Washington University and the current National Academy of Medicine Nurse Scholar in Residence. I have the pleasure of moderating an incredible panel today that will start us off in this webinar, and then we'll be able to open it up to questions from the audience, some of which we've gotten already. We've gotten quite a few from different folks, but we are really excited to hear from many of you today. So if you do have questions, we would encourage you to go ahead and put them in the chat box so that we can get them for you all as we get to the question and answer session in a little while. So first, I want to introduce the presenters that I'll be presenting today. The first is Dr. Peter Bierhaus. He is a committee member from the National Academy of Medicine Future of Nursing Report, a professor of nursing in the College of Nursing at Montana State University, and the director for the Center for Interdisciplinary Health Workforce Studies, again at Montana State University. Next, we have Rear Admiral Dr. Aisha Mix. She is the Chief Nurse Officer for the Commissioned Corps of the United States Public Health Service. Third on our list today is Dr. Sheldon Fields. He is the Associate Dean for Equity and Inclusion and a research professor at the College of Nursing at the Penn State University. Finally, we have Ebony Haley. She's a nurse care coordinator for care management initiatives at the Camden Coalition of Healthcare Providers. The goal today is to learn how the nursing workforce can be strengthened and diversified through education, preparation, and leadership. And as a result of this participation in this webinar, you will learn about current and projected future state of the nursing workforce. You'll understand how and why nursing education needs to be strengthened to better address social determinants of health and advance health equity. And you will learn how and why the nursing workforce should be diversified to better address the social determinants of health and address health equity. So that is my sort of welcome for you all. I wanted to make sure you all knew who we were talking about and who we were going to be talking to. The vision of this report is the achievement of health equity in the United States built on a strengthened nursing capacity and expertise. By leveraging these attributes, nursing will help create and contribute comprehensively to the equitable public health and healthcare systems that are designed to work for everyone. To achieve health equity, the report envisions a major role of the nursing profession in engaging the complex work of aligning public health, healthcare, social services, and public policies to eliminate health disparities and achieve health equity. As the largest and most trusted segment of the healthcare workforce, nurses are well suited to help support our country and advance health equity. But nurses need more support from health systems that educate, pay, employ, and enable us to do our work. And across the board, we need to value nurses and the work we do to keep us all healthy. I'm honored to introduce our first speaker and committee member, Dr. Peter Bierhaus. Dr. Bierhaus will provide an overview of the current and future nursing workforce. Dr. Bierhaus, this is up to you now. Welcome.
Okay. Well, thank you, Ashley. And I also just want to say thank you to you for all the work that you did to help support the committee. You really made a positive difference, and so I think you need to be publicly acknowledged. So I've got a lot to say today in the next 15 minutes, and I'm wondering if, Toshi, if you could go ahead and advance the next slide, please. There we go. Go ahead, next slide, please. So I'm going to first talk about the current workforce. We had a lot of strengths that developed over the 2 decades leading up to the pandemic, and I'm only going to be able to talk about 2 of them, those that I think are most sort of relevant to today's webinar. Then I'll move into the future workforce. Here we'll talk a little bit longer, and we'll discuss 7 challenges that many were building prior to pandemic and then exacerbated by the COVID pandemic, and then we'll have implications going forward into the future. So that's sort of the layout of where I'm at. Next slide, please. I wanted to disclose the past and current funders of my research and my board and related memberships, both kind of current and recent, and say to you that I don't believe any of these relationships bias my presentation in any way. Next slide, please. So here are 10 strengths that we're developing in the 2 decades, 2000 to 2020. I wish we had time to go through all 10, but we don't. So I'm only going to talk about the first 2, about an increasingly educated and diverse workforce and the positive public perceptions of nurses, Ashley just mentioned a minute ago. We'll see this slide again, but I just want to pause for a second to allow you to just sort of absorb what was going on in these prior 2 decades. Lots of positive developments. Okay, Toshi, we'll keep moving. So the first strength is we have an increasingly educated and diverse workforce. And by that, if you look back the last 10 years, each year we've been producing more registered nurses with a bachelor's degree than with an associate's degree. We've also had a dramatic increase in the number of nurses with a master's or higher degree. You can see the numbers back in 2 decades ago, 6,000 produced each year with a graduate degree. Today, it's roughly 50,000. Next slide. We've also become more diverse. If you look at this table, you see that in 2018, according to the National Sample Survey and other data sources, we had about 69% of the population were white in the country, were in nursing. 69% of nurses were white compared to 76% of the population who were white. For Blacks and African Americans, about 12% of the population of nurses were Black or African American, almost equal to the 13.5% who in the population. Asian registered nurses at about 9%, far exceeding the 6% or so of Asians in the population. Hispanics only at about 7% compared to almost 19% in the population. But the good news here is that the numbers of Hispanic RNs are increasing at a very rapid pace. So I'm encouraged in thinking that over this next decade, we'll really narrow that, this discrepancy here. Next slide. This looks at the education of nurses. And I think the big take-home message is that in most areas, whites are the least educated in our workforce. You can see this if you look at, say, the orange part of each bar. This corresponds to the percentage of nurses with a baccalaureate degree. So 48.8% of white RNs have a bachelor's degree compared to 52.7% for Black African Americans, 69% for Asians, 49.8% for Hispanics, and others is higher as well. This is a similar pattern when you look at master's prepared nurses and PhD nurses. So we've grown more diverse, and we've done a pretty good job with education at this point. Now we'll need to improve on this as we go forward, but we're starting off not at zero, but in a good place, I think, overall. Next slide. Now, the second strength that I want to talk about is over these past 2 decades, think of all the disruptions we've had in healthcare, in our society, our demographics, our politics, technology, etc. All of these were occurring, and yet today still the public trusts nurses above all other professions and occupations in the country. Now, research has shown that the reasons for this is that the public views nurses as being there to protect them and keep them safe, to assure high quality of care, and to provide advice on personal health issues. That's sort of what's driving this high public trust. Next slide, please. And I want to take us back just prior to the development of the pandemic in 2020. But this was a survey conducted by the Commonwealth Fund, the New York Times, and Harvard School of Public Health. And it was a very, very large in-depth survey of the public's attitudes about healthcare. Turns out that in one of the questions, they asked who the public trusts to improve the US healthcare. This slide shows that in response to who the public has a great deal of public trust, it's nurses across the board. 30 percentage points higher than the next group, physicians, and even more so than hospitals. And it didn't matter if you were a member of the public who said, I want Medicare for all, or let's just improve the ACA, or others who said, let's get rid of that Affordable Care Act. It didn't matter. Nurses were 30 percentage points above all others in the public's view of improving the healthcare system. Next slide. Now, we're all familiar with the annual Gallup Poll done every December, looking at honesty and ethics among all the professions. And here you see in green that nurses have been leaders for many years, actually, roughly in the 80% of the public viewing nurses as the most trusted. And sure enough, in 2019, 85% of the public felt that way, 20 percentage points above that of physicians and engineers. Now we get into 2020, the public has observed nurses doing all of the work and suffering and physical exhaustion and saving hundreds of thousands of lives. And so the public's view rose to 89%. Now you might think, oh, that's not much from 85 to 89, but you're already at this super high level of 85. So I was really surprised, but not totally, but 89%, that's amazing. Even the public viewed physicians and pharmacists higher as well. So they took a jump. Next slide, please. So I'm going to come back to that in a few minutes, this public trust. But here again are these strengths. Again, I just wish I had time to go through all of them because it's pretty cool to feel all this nice wind at your back moving us forward. And that's good because the next slide shows we've got a bunch of challenges that we're going to be looking at as well. And so, let's just jump right ahead, Toshi, and move into the next slide. So the first challenge is this big gap between where the population's health needs are and what the capacity of the nursing profession to address them. So we all know that the baby boomers are retiring. This is around 77 million, and they will be retiring in record numbers over this next decade and aging up over 60s, where they will have 3 to 4 times more conditions, complicated conditions, chronic conditions compared to younger people. And we'll have millions in growing numbers of frail olders. So we have a major growth in the need for geriatrics care. Mental health and behavioral health. This was large before the pandemic, but the estimates now are all over the place, but they're all going north in terms of the number of people with diagnosable mental health conditions and other issues in behavioral health. So the estimates are 40 to 80 million people. Then we have the gaps in primary health care, which have been growing, not decreasing, but growing over the past couple of decades. It's now estimated about 80 million people have inadequate access to care. And then maternal mortality rates have been climbing and climbing. I think they're now sort of leveling and coming down. I'm not sure about that 16%, if that's the current rate, but it's not much lower or much higher at that point. I think that's a good number to be thinking about. That's still awfully high. So we've got those issues. Now, a minute ago, I said, hey, the undergraduate RN workforce was showing some good trends in diversity and education. Not so with the advanced practice registered nurse workforce. Look at Chapter 3 in the NAM report, and you will see information about how, quote, white this APRN workforce is. Now, the good news is many of these APRN workforce is working with people of color and in difficult areas in inner cities and in rural locations. But we really need to focus in on increasing the diversity of the APRN workforce. The point I want to try to make is growing population needs in these categories, but we don't have the numbers of nurses trained in these particular specialties located where they are needed the most. Big gaps that could get bigger if we don't pay attention to this very first challenge. Next slide, please. Now, we've got another big challenge, which is the retirement of the baby boom generation of nurses. So you see here that the 1.2 million baby boom RNs are expected to have all retired by the end of the decade. Between now and the 2030, that's about 640,000 nurses, or about 70,000 RNs per year born in a generation. We've never had any experience with this kind of a large retirement in our history. Next slide. We tried to estimate the loss of nursing experience, and we published this a few years ago. The blue lines, or the blue dots to the right of the chart, indicate that between now and 2030, every year we will be losing, more than 2 million years of nursing experience will be lost to our workforce. So we have a significant loss of clinical leadership, organizational know-how, mentorship, etc., that goes with many of these registered nurses who will be retiring. Next slide. Third challenge is we have this inadequate capacity of the physician workforce. We have shortages of primary care physicians and shortages of non-primary care physicians. These are continuing to grow, to generally worsen over time, not get better. And it's compounded by the uneven distribution of the physician workforce, not enough in rural areas particularly. So this means that the gaps in the physician workforce will spill over onto the registered nurse workforce and the APRN workforce to make up the difference. Now, unfortunately, we have 23, 24 states that still restrict the scope of practice of nurse practitioners, particularly. And so when we should be taking care of these patients, making up these gaps, many of us will be continuing to sort of struggle through and trying to get some relief from these restrictive scope of practice, wasting our time there when it could be better spent taking care of patients. Next, Oshi. So the fourth challenge is we are in a decade where we're likely to see a rapid evolution in the adoption of value-based payment. And that's running into a nursing workforce that, in my view, is completely ill-prepared for that payment environment. That environment will reward providers more for producing higher value and pay them less for lower value care. But nurses don't seem to understand how value works. We don't have time to get into it today, but it concerns me that the payment system is going in a direction that could be very advantageous to nurses, but we're not thinking about it. We're not prepared enough for this. Now, the good news is that the AACN, the Association for American Colleges of Nursing, in their recent documents on essentials for baccalaureate education, have now put in value and costs. So hopefully this is going to be addressed, but we better hurry up and get on with that pretty quick. After all, there's a chapter in the NAM report that talks about paying for nurses. And we need to be ready to take advantage of value-based payment to further our opportunities to address social determinants and health equity. Next slide. This challenge is really something that has developed now with the COVID pandemic, struck right in the middle of our NAM committee deliberations. But to me, there are two big issues. What's going to happen in terms of entry into the workforce? Will this pandemic lead to increases or decreases in enrollment into nursing education programs. Now, last fall 2020, enrollment still was going up, but applications were not going up as much as in prior years. So a little bit of a thing to watch there. I'm anxious to see what happens this fall. Now, the other aspect that I think we need to be thinking about a lot with COVID is exit from the workforce. Is the pandemic going to lead nurses leaving the workforce? I've had enough. This is doing me in. I didn't get into this. I didn't see this coming. I'll find something different. Or is it going to speed up the retirement of those 640,000 RNs who say, man, I was going to go a couple years later, but not now. I'm done. This has just worn me out. Now, if that happens, then we're going to have a very sudden and swift exit out of the workforce. That could have some significant disruptions. And we really have to be paying attention to how the entry and exit issues play out. Because one of the things that our team did prior to COVID is we estimated that what the number of nurses would be over this decade. And we estimated the workforce would grow by 1 million RNs between now and 2030. And that is at risk with the pandemic. So that's the fifth challenge. What's going to happen? How are we going to manage it? Go ahead, please. A couple more slides. And now we have implementing the report's recommendations. If you haven't seen the report, buckle up and sit in a comfortable chair. It's a long report. It's an extraordinary report. It's just huge with information. There's a lot of recommendations. There's a lot of work put before the profession here, and we'll get into that with this webinar today. Next, please. The last challenge I just want to bring up is not in the report, but it's something that I wanted to just put out there. And I recall we talked a lot about that relationship with the public and how the public admires nursing so much and trusts them. And when you go back over the past decades, you see tremendous outpourings of private sector and public sector support for nurses. Nurses are important. But will the public begin to lose trust in nurses who are not vaccinated? After all, what drives that trust is the view that nurses are there to protect and keep them safe, assure high quality of care, and personal advice on health issues. How will the public view nurses who do not get vaccinated? Alternatively, or flip that around rather, how will nurses look at the public who refuses to vaccinate? Will nurses give up on the public, say, I can't risk my life for this? And so I'm a little concerned that we may be seeing the emergence of a change in this very positive historic relationship. So it's something that I think is important because we need mutual trust, the public and nurses, if we're going to address social determinants of health and if we're going to achieve health equity. Both hard work to do. It's going to take time. We need all the trust we can. All right, I think I'll sum up next with this last slide, which is lots of strengths have built up. We should leverage them. We should need to be aware of them. We have a lot going for us. At the same time, we also have significant challenges that we're building before the pandemic. They've increased and they've grown even a little bit more complicated now with the pandemic. I'm a little worried about this mutual trust because that could underpin lots of our future efforts to achieve the NAM's recommendation on the future of nursing. So I'll stay, thank you, and we'll pick it up later. And I hope, Ashley, I'm relatively on time.
Yes, thank you so much, Peter. That was excellent. I did want to just ask one question that came through on Pubble is about American Indian data and the lack of American Indian data that we had in some of the data that you showed today. If you could just speak to that for a moment.
Right. The data sources that we had at the committee, despite an awful lot of effort by a lot of folks, were not good on American Indians. But we were able to get some data, and that's in a big text box in the workforce chapter. I don't have it in front of me, but we do talk about we need to do better in the future, particularly with this part of our population. So I'm glad you brought that up, and I hope we can really make improvements in that regard.
Great, thank you. I'll see if we can refer back to the report there so we can get that out to the person that asked. So thank you so much. Great, well, next up we have Dr. Sheldon Fields, and he's going to be speaking on the the nursing workforce's role in addressing social determinants of health and advancing health equity, specifically why a diverse workforce is needed. Thank you, Dr. Fields. I'll give it to you now.
Okay, thank you, Ashley, and thank you for the opportunity to present today on this really important topic. So next slide, Toshi. So this quote by Martin Luther King, of all the forms of inequity, injustice in healthcare is the most shocking and inhumane, is the one that I use most in these presentations because I think it really underscores the heart of what we're talking about in terms of being able to even think about moving towards health equity. Next slide. So I really enjoyed Dr. Beerhouse's comments about where we're at with nursing. But in terms of the overall distribution, at mainly female and mostly white, the profession of nursing is not diverse. And we've made some progress, this is true. But we also have some problems with the distribution of the nursing workforce, similar to what we see with the physician workforce. We also have some areas where the nursing workforce just does not mirror in any way the populations in which they serve. The other issue I want to bring up here is that when I talk about diversity of the nursing workforce, I do not limit my perspective to only race or ethnicity, because diversity in nursing means many, many things, including gender. And we haven't made the progress in increasing the number of male nurses that I think we really should. And this statement here that was by the National Academy, that the decade ahead will demand a stronger, more diversified nursing workforce that is prepared to provide care, promote health and well-being among nurses, individuals, and communities, and address the systemic inequities that have fueled wide and persistent health disparities. So we really still have some work to do. Next slide. So, and why does that so important? So I know that most of you all know and have seen and have heard and have seen other reiterations of the social determinants of health. And this slide by Kaiser is the one that I use in all my presentations because I think it's the one that is so well done, because it talks about the social determinants of health over many different sectors, whether it is from an economic standpoint or the physical environment to those educational factors to food, community, and then the healthcare system itself. Now, no matter what sector you take and you look at the social determinants of health, we are really talking about the health outcomes, the increased mortality and increased morbidity and decreased life expectancy of the impact of the social determinants of health on BIPOC communities versus majority white communities, which leads to the whole issue of healthcare disparities. So I won't reiterate, you can see on the slide the various topics here. So next slide. Because this leads to this other discussion about healthcare disparities. And the World Health Organization's definition, which is the differences in health outcomes that are closely linked to socioeconomic and environmental disadvantage, that are often driven by social conditions in which individuals live, learn, work, play, I often add die, because from a nursing perspective, we take care of people from the cradle to the grave. And I think that's really important to sort of underscore. So the healthcare disparity issues we know are familiar with, and we know what some of them are. We know what causes a great number of them, but we haven't really made the inroads and really decreasing a lot of healthcare disparities, we still live with a vast number of them. In a statement on a slide that when white folks catch a cold, Black folks get pneumonia, just simply underscores the disparate impact that happens from even a minor rhinovirus. Next slide. So what does this all have to do with nursing? So, nursing overall has a sacred obligation to society to take care of everybody with the same level of human dignity and compassion. But we can really only do this if we have a nursing workforce that is representative of the society in which we have been called to serve. So this statement here, racism manifests in healthcare through health disparities, is one that I want you to sort of keep in mind as I finish and go through the presentation today, because nursing is well positioned to really impact healthcare disparities and to work on increasing health equity. And nursing really must put forth a more aggressive plan to diversify the profession on all levels. Next slide. So as we move towards health equity, I want to be really clear about what we mean when we talk about health equity, because there are some varying definitions. So, the National Academy defines it as health equity being a state in which everyone has the opportunity to obtain full health potential, and no one is disadvantaged from achieving this potential because of social position or any other socially defined circumstance. Okay, well, the World Health Organization defines health equity as the absence of unfair and unavoidable or unremediable differences in health among population groups, defined socially, economically, demographically, or geographically. And while I like and appreciate these two definitions of health equity, I really want us to think about simplifying it a little bit and using a definition of health equity that I believe, while simpler, is a little bit more eloquent and actually really, I think, goes to the heart of what nursing can really do. So next slide. And that is the definition of health equity put forth by Dr. Kamara Jones, the former president of the American Public Health Association. And Dr. Jones defines health equity simply as the assurance of the conditions for optimal health for all people. Again, I think it is such a more eloquent definition of health equity. Sometimes less is more. And in this case, I think it really gives us a lot of room to work with. Because Dr. Jones also further goes on to say that in order to achieve this level of health equity, that we have to do it through three principles: providing resources according to need, valuing all individuals and populations equally, and recognizing and rectifying historical injustices. Next slide. And if we do that, then we are really working towards achieving health equity. But I really want to point out two things here. Achieving health equity is not going to be possible unless we do two things, unless we figure out how to seriously and proactively and purposely confront structural and institutional racism. And nursing in particular has to figure out how to embrace and stand up and put forth anti-racism initiatives. And as the slide says, the beauty of anti-racism is that you don't have to pretend to be free of racism to be an anti-racist. Anti-racism is the commitment to fight racism wherever you find it, including in yourself. And it's the only way forward. Next slide. So we talk about the social determinants of health. My good colleague Daniel Dawes talks about the political determinants of health. And I want to take a moment and talk about the nursing determinants of health. And I really want to challenge my nursing colleagues just to think about this. There is no other healthcare profession that interacts more with patients than nursing. We have so many touch points along the patient care spectrum. Each interaction is an opportunity. So what do I mean by that? It's an opportunity to get it right. It's an opportunity to provide the best care. It's an opportunity to intervene. It's an opportunity to leverage your care in the most humanistic, respectful way possible. It is full of opportunity. Nursing is truly everywhere in our healthcare system, and we are ideally placed to confront structural and institutional racism. Nursing is also situated to lead anti-racism initiatives, and we have to do so more purposefully and intentionally. Nursing is also morally and ethically obligated to provide equitable care to everyone, regardless of their demographic characteristics. I don't care what they are. Nursing can impact directly healthcare disparities and the social determinants of health as well. Next slide. So the report that we're talking about actually addresses this. So in a section where it talks about health equity being achieved through 10 desired nursing outcomes, it talks about how nurses are prepared to act. And that's what I was talking about, alluding to earlier, those opportunities across all the various sectors and all the various populations and specialty areas. And it points out this last point here. The elimination of the disparate disease burden carried by specific segments of the US populations. That is the healthcare disparities that we're talking about and the differences that we continue to see, especially in BIPOC and underserved communities. But nurses also reflect the people and communities that they serve throughout the nation. And it talks about helping nursing to ensure that individuals receive culturally competent, equitable healthcare services. We can do this with an increased diverse nursing workforce, which is what the last line says, that healthcare systems must enable us to tailor the specific needs of those diverse populations and patients to optimize their care. Next slide. The report also goes on to talk about the nursing role in leadership. And I really like that the report talks about how nurses have a responsibility to address structural racism and cultural racism and discrimination based on all of those various things that they list here. But we also need to do it within the nursing profession, and we need to help build those structures. And the last recommendation I just want to point out here is that it really talks about nursing in terms of its research agenda, to develop and support a research agenda and evidence base that describes the impact of our interventions and really talks about nursing also needing to take care of itself. Next slide. So as I think about what we really need to do, and I conclude my comments, so with a diverse nursing workforce, we know from the research that patients generally fare better when care is provided by a more diverse team. We also know that professional skills-focused studies generally find improvements in innovation and team communication and improve risk assessment with more diverse teams. We also know that there's a financial impact that nursing has. And that financial performance is improved with increased diversity. Lastly, with a nursing workforce that is more diverse, we can create diverse, friendly environments that are key to avoiding the frictions that come with change. And there is nothing more endemic in our healthcare system than change. So those are what I would really want to underscore as the need to increase the nursing workforce diversity. And those of us who are primarily on the academic side of things really needs to push things such as holistic admissions for nursing schools and really looking beyond the elements that we think about or who can be a nurse, because there's a lot of barriers of entry to nursing that I don't think are necessary. Colleges and universities are getting rid of SAT scores and ACT scores for undergrad. We need to do something similar in nursing and getting rid of things like the TEAS test, because I think this just provides another barrier. Next slide. So I hide in public. I always answer to answer questions. Next slide. I left you with some references, and that will conclude my remarks. Thank you, Ashley.
Great. Thank you, Dr. Fields. We're so grateful to have had you today. Next up, we also welcome another wonderful speaker today. Rear Admiral Dr. Aisha Mix is the Chief Nurse Officer of the Commissioned Corps of the United States Public Health Service, and she will describe the Public Health Service's role in diversifying the nursing workforce. Thank you for being here, Rear Admiral, and please go ahead and continue for us.
Excellent. Thank you. Good afternoon and good morning to some. It is certainly an honor to be a part of such a prestigious panel and also to discuss a very timely and important topic for our profession, and of course in the context of the United States Public Health Service. Next slide, please. I do want to start my part of the discussion with some principles that apply across public health nursing. So the socio-ecological framework is probably not new for many of you, but it is one that presents the relationships between individual, family, community, and the systems within which we live, work, learn, worship, and play. It really is a complex interplay where the actions that occur at one level influence factors at another level. Next slide. So when we add in today's topic for discussion, this graphic is actually how I relate to the socio-ecological framework and the concepts of diversity, inclusion, and equity. So while they're related, and just as you've heard in the prior presentations, they're certainly separate and distinct concepts in and of themselves. Diversity, as it's defined by HHS, it's all the ways in which people differ. And just as we heard, because I do agree that diversity includes characteristics such as age, race, gender, national origin, mental or physical ability, sexual orientation, but it also includes those characteristics that are acquired. So these are things like education, socioeconomic status, religion, work experience, language skills, family status, and a number of other things. So diversity ends up being that thing that we use to establish and define groups of people. And so therefore, it determines that we have a, quote unquote, diverse workforce or a diverse community or other collection of people. When we move into a conversation of inclusion, however, inclusion is actually a process. It's a process that involves enabling a full participation and contributions of the diverse groups of people by eliminating implicit as well as the explicit barriers. So this process then, it reflects the organizational practices. So these are the practices that must focus on the needs of the individual and also create conditions where each person can achieve their full potential. So the environment itself is what ends up being inclusive. So it's not a function, it's not a role, and it's not the responsibility of the diverse groups that were previously mentioned, right? So moving the conversation forward, it reaches equity, right? So when you're achieving equity, you're at a point where there are no avoidable or remediable differences that exist between the diverse groups of people. And so in the context of health, we're of course familiar with health equity, and in the process of ensuring equality and access to resources in order to improve and maintain health and address inequalities. So as the definition was shared earlier, the WHO goes further than that. So the WHO talks about interventions that address health equity in making sure that it actually includes empowerment of the people who have actually been impacted by the inequality, the inequity, or other disempowering systemic practices. Next slide. So diversifying the nursing workforce then is only one step in addressing the larger problem that's actually facing our profession and all of the nation. So achieving this health equity is going to require systemic change, and it's going to have to be driven through policy and program development and enforcement of the inclusion practices across all of our work environments. What this will do is it will eventually allow every nurse in our workforce to practice freely and confidently in their professional and authentic version of themselves. This will absolutely take all of us. And so while you consider your part, right, because I'm only here to talk about and share with you the role of the federal public health service nursing, but I remind you that this is not a job that any one of us can do individually. Next slide. So just a bit about who we are. So as Chief Nurse of the United States Public Health Service Commission Corps, I actually advise the U.S. Surgeon General as well as the HHS Secretary on issues that are related to and impact over 4,000 civilian and active duty public health service nurses. All of us are working within HHS. There are 11 operating divisions. We have nurses represented across 10 of the 11 operating divisions within the Department of Health and Human Services. I'm certain that many of you can identify the specific agencies based on their descriptions of the programs that are listed on the screen here for you. I wanted to point out, though, that within federal public health service nursing, we have our civilian as well as our active duty commission corps force. So as an active duty deployable force of over 1,300 nurses, the PHS Commission Corps nurses serve alongside our civilian colleagues, and we also respond to disasters and public health emergencies across the nation and the globe. So it goes without saying that all of our workforce could stand to diversify in order to achieve this health equity that we talk about. But again, we have to start with us. Next slide. So I want to bring us again back to this topic that we're talking about today as it relates to nursing workforce development. The HHS Secretary actually delegates responsibility for Title VIII or nursing workforce development under the Public Health Service Act to the administrator of the Health Resources and Services Administration, also known as HRSA. Then HRSA, through its programs and with coordination of the National Advisory Council on Nurse Education and Practice, is then charged with enhancing the composition of the nursing workforce and improving distribution and the utilization of our nurses to meet the needs of the nation. They're also charged with expanding the knowledge, skills, and capabilities of nurses in order to have a quality nursing practice. There's a charge to develop and disseminate improved models of organization, advise on the financing and delivery of nursing services, and also to promote interdisciplinary approaches to health services, particularly in the areas of public health and primary care. Because I remind you, while nursing is often the glue that holds a lot of the healthcare system together, none of what we do operates in a vacuum. So the HRSA Division of Nursing and Public Health is specific in their responsibility for administering and providing oversight for the nursing, behavioral health, as well as our public health federal programs. Next slide. So this is interesting to note, and following the discussion from the presenters today, I think what this slide really does is it allow us to look at some of the principles that were shared and actually focus on what application of it looks like as an intervention to address health equity. So the Nursing Workforce Diversity Program within HRSA is within, of course, the Division of Nursing and Public Health, and it's one of the many programs that are designed to address factors that impact our nursing workforce. So NWD provides grant funds to eligible entities, and the purpose is to increase educational opportunities for students from disadvantaged backgrounds, and that includes students who are from racial and ethnic minority groups that are underrepresented among registered nurses. The projects that are funded under this program are responsible for identifying and assessing the needs of the target population of nursing students with a focus on the social determinants that impact recruitment, retention, and graduation. So when you look at this based on a socioecological framework, which is where I started out today, so at an individual student level, HRSA's approach to achieving health equity and decreasing health disparities is centered around the nursing students themselves. So that's through the provision of student support, through mentoring, and also the financial assistance that's needed to address their individualized needs. At the organizational level, there's faculty recruitment and retention and mentoring practices that are centered around the organizational practices. And these are organizational practices that are intentional in promoting a diverse nursing faculty that is actually capable of engaging and empowering nursing students. At a policy level, at our federal level, HRSA actually has requirements that enforce its focus on embracing the uniqueness of each student. How this is done is by requiring that holistic review as an admission strategy. So this is the same thing that was just spoken about. So the strategy serves to promote diversity by assessing not only the traditional aspects of academic achievement, right? It's important to look at grades, it's important to look at test scores, but it's also important to assess a student's background, their qualities, and their specific skills that they're bringing that will allow for them to be successful within the context of the nursing profession and our community. So in my role within Federal Public Health Service Nursing, next slide, please. This also means looking at the structures that are related to workforce planning, forecasting, recruitment, and retention efforts in settings across the care continuum. The slide in front of you shows the CNO priorities, or Chief Nurse Officer priorities, not only that I have as a part of the Commission core, but also for HHS nursing and my engagement with nursing, even on the international level. So it's important that we ensure that nursing education supports the integration of population health concepts, and that includes social determinants of health. And it needs to be incorporated in all levels of nursing education. Our graduates must be equipped not only with the knowledge of health outcomes, but also of the factors that influence disparate outcomes. So whether we are advocating at the individual, community, or systems level, we have to engage public health leaders, public health nurses who are these leaders, so that we can continue to improve and protect health. All nurses, regardless of race, ethnicity, socioeconomic status, gender, sexual preference, all of us should be and should also be active in seeing ourselves as leaders and having opportunities to develop leadership competencies long before we're ready to even accept these executive level opportunities. This means that the door has to be open, the window has to be opened, the environment has to be conducive to seeing myself as the leader that I want to be in the future. When we look at practice, the practice environment is also another crucial factor in modernizing our health and care delivery. Our workplace policies must support everything that we're saying today. It looks really nice on paper, but we have to translate this actually into practice. So our policies have to support the ethical care and treatment not only of the populations we serve, but also of the nurses we serve. It does us no good to remind nurses every day, in and out, of how we have to treat people fairly, how we have to respect the needs, respect the differences of our patients, while we find ourselves not receiving that same treatment within our work environment. So having a diverse nursing workforce then is a commitment to celebrating the biological, psychological, social, cultural, and spiritual factors that create our community and spark our unique experiences that guide us in this art and science of care. Next slide, please. So I like to share this picture because what this picture represents for me is really a true testament to the work that I'm doing and the work that the nurses that I represent are doing across this nation. In the context of this COVID-19 pandemic, where so many are struggling so hard to do the very thing that is of their nature, to be a registered nurse, it's often times like these where, I take the time to remind each of us, it's not just that outward facing and the hand that we hold and that person that we touch. We must also take a look and turn that lens inward, because we have to make sure that we create and sustain a workforce that's going to be available and ready and looks like and acts like the communities that we're charged to serve. So I thank you again for this opportunity to join you today. And I look forward to our continued work and discussion together as we protect, promote, and advance the health and safety of our great nation. Be well and stay safe. Thank you.
Dr. Nix, thank you for that. That felt really inspiring, and I feel grateful to have you as part of the service serving the rest of us here. So thank you again. Next up, we have Ms. Ebony Haley, and she's going to talk about, during this portion of the webinar, she's going to talk to us about her experience as a care management initiative at the Camden Coalition, healthcare providers, and her experience as a nurse in that aspect of care. So we're really excited to have a nurse's experience here, to have sort of real life frontline clinician here with us to speak to exactly some of the topics we've been talking about today. So Ms. Haley, please take it away.
Hello, everyone. Such a pleasure to hear all the content thus far. Very informative and sparking the movement. I'm excited that it's the year of the nurse and to be here with you guys. Today, I will be discussing the benefits of working at the Camden Coalition while being a nursing student, factors that are important in considering preparing nurses to achieve health equity, and what is needed to diversify the workforce and supports that are needed to make it happen. So what are the benefits of working at the Camden Coalition while in nursing school? There are many benefits working at the Camden Coalition while being in nursing school, such as the support, from mentoring to tuition assistance, educational paid time off, professional development money. The support is here. The Camden Coalition has prepared me to go out into the community and help individuals with complex health and social needs by training me in motivational interviewing, crucial conversations, harm reduction, trauma-informed care, addiction medicine, student hotspotting, mental health, leadership, and relationship building. With the knowledge I have acquired during my 7 years at the Camden Coalition, I now have a different outlook and approach, whether it's in a classroom, at my place of employment, or in my personal life. In the classroom, I am able to model behaviors and skills that I have learned for my peers. Using my crucial conversation skills, I am able to provide honest, real-time feedback to my patients, fellow students, and instructors with confidence. Working for the Camden Coalition has been an extraordinary benefit to me and the community. I can now anticipate possible barriers that my patients may face during my clinical rotations. I felt prepared, and I knew I had all the tools I needed to help my patients. Using motivational interviewing skills to ask open-ended questions to elicit more information allows me to fully understand the barriers that individuals are facing, creating an effective care and discharge plan. A patient who is homeless, newly diagnosed with diabetes, and his discharge instruction states, take your insulin every 4 hours with meals. When you take a step back and you think about that, and think about some of the possible barriers this patient may face, many individuals look at it and just look at the meals. How is he going to get access to meals? When I look at this from a whole person lens and a harm reductive lens, I think about he's getting vials of insulin that he has nowhere to store it. Can potentially be staying in a shelter where they won't let him bring needles because that's considered paraphernalia. How is he not going to readmit? So by looking at that and looking at the bigger picture and asking open-ended questions to figure out what are some of the barriers the patients are facing, maybe I could have advocated for him to get pens instead of vials. That way he's still able to take his insulin, and then get him connected with a couple food pantries in the city for food. Patients who do not often follow the instructions recommended by physicians are sometimes labeled as being non-compliant or the frequent flyers. I'm sure at some point we've heard that, or we've even read it in patients' charts. I'm sure I wouldn't want to be called non-compliant. And I'm sure patients don't want to be called non-compliant. I don't think they're non-compliant. I think they're misunderstood. Factors that are important in considering preparing nurses to achieve health equity. Nurses on the front line of healthcare are uniquely positioned to screen for social determinants of health and positively address health equity. Your nursing staff should look like the population that you are serving, which will help with cultural competence and relationship building. The role of the nurse in addressing health equity and the social determinants of health must be strengthened. Social determinants of health as the condition in which people are born, grow, live, work, and age that impact their health. The ability to address specific social determinants of health that impact our patients and then connect them with specific services has the potential to change quality of someone's life. Integrating social determinants of health into the nursing curriculum is a great start, but I believe that it needs to be in conjunction with hands-on experience, something like student hotspotting. Student Hotspotting Learning Collaborative is an annual program that trains interdisciplinary teams of professional students from schools around the country to address complex medical and social needs using a patient-centered approach. Student Hotspotting is part of the Camden Coalition of Healthcare Providers' effort to educate and provide mentorship for next generation of healthcare professionals, and is run through our National Center for Complex Health and Social Needs. Student hotspotting will allow future nurses the opportunity to learn coursework about social determinants of health, but also have hands-on experience, where they will be able to use the tools learned in the classroom and translate them into practice, including but not limited to the following skills: motivational interviewing, the coach model, trauma-informed care, and harm reduction, which will equip new students with the tools that are needed to deliver care. Nurses being equipped with the proper tools is one way we can begin achieving health equity. Health equity is achieved when every person has the opportunity to attain his or her full health potential, and no one is disadvantaged from achieving this potential because of social position or other socially determined circumstances. Health inequities are in reflected length of life, quality of life, rates of disease, disability, and death, severity of diseases, and access to treatment. What is needed to diversify the workforce and supports that are needed to make it happen? Let's change the narrative. We cannot continue doing the same things and expecting different results. What is needed to diversify the workforce starts with the admission process into schools. Most schools only take into consideration what is printed on a person's transcript. Me, for instance, my transcript is the reason that I can't get into a BSN program now. But if one school would look at me as a whole person and not what's on paper, understanding that every withdrawal, every drop class, every grade that's below a C has a story behind it. When I finally got myself on the right track and I was ready to apply again, I was hit with, my sciences are expired. I have to retake them. So now I retook my sciences, and now it's maybe for the schools in my area, they each require a different entrance test. So barrier after barrier after barrier. And it's not just siloed to me. Other LPNs that I have talked to are having similar barriers to getting into school. And back in 2014, the Robert Wood Johnson Foundation Upward Mobility Nursing Scholarship Program provided a BSN education to unlicensed assisted personnel currently employed at Cooper Hospital. It was funded by a $250,000 grant from the Robert Wood Johnson Foundation through its New Jersey Health Initiative, New Path to Professional Nursing Program. Through this program pipeline, Rutgers, Camden, and Cooper collaborated to grow a diverse workforce of bachelor's prepared registered nurses from historically underrepresented groups to better meet the healthcare needs of the community we serve. A program like this is a way to diversify the nursing work field. That's all I have for you guys. Thank you.
Still on mute here. Thank you so much, Dr. Haley. We really appreciate your time today, Ms. Haley. And we are so grateful for the work you've done at the Camden Coalition. The next part of this, for the next 25 minutes, we have the opportunity to ask our panel questions. And we've had a lot of questions put in the chat box. We've had a lot of questions sent to us prior to our chat today. So I'm going to sort of just jump right in and give questions and try to target the questions to the speakers and the panelists that it seems most relevant to. But I want you all to know that you can absolutely jump in to answer if you feel like you you're the right expert for it. So please do that. So I'm going to start with Rear Admiral Mix. What about public health nursing pipeline, or how can we develop a diverse pipeline in public health nursing? So you gave some really great examples today, sort of a little bit more broadly speaking, sort of out within the public health service, but even sort of more broadly, if you have any recommendations given your experience and your area of expertise, that would be great.
Excellent, and thank you for the question. I think it's a larger conversation of how do we make sure that registered nurses are aware of what public health nursing is as a specialty. Oftentimes, the introduction to community health nursing occurs, in that introductory program of nursing, right? And so within the context of community health, nurses have to learn how to expand their thoughts and their processes and their interventions and begin to address not only the needs of the individual patient, but also the families and also the very communities that, again, we're a part of ourselves. So in order to develop and maintain this pipeline of nurses to continue into the public health specialty, we have to afford them opportunities to be exposed to these types of skill sets. And so we're talking more about connections and partnerships with public health offices, whether they be at the state, the local, the tribal, the territory level. And we have to allow nurses to have rotations in areas of that sector that are not just a public health clinic, right? Because public health nursing as a specialty ends up bringing in and engaging skills such as surveillance and advocacy, outreach, policy development, community organizing, coalition building. And lastly, there has to be an intentional focus on diverse learning experiences that incorporate diverse learners, faculty, and leadership. On a personal note, I try to make sure that I'm visible, right? Because my story is one that I wanted to connect with someone else out there. As a 15-year-old mom, and now sitting here as the chief nurse of the United States of America, that's a story that needs to be told, because there is a teen mother out there who no one has ever told her that she can do it. And so I stand here before you and everyone to say, yes, you can. If that's the path that you're choosing, yes, you can. And I think some of the factors that came into that being have to do with the supportive environment, again, that was created to ensure that I succeed. So again, I think those partnerships, not only academically, but also in the community, leveraging your minority serving institutions, including your HBCUs, your historically, your HSIs, Hispanic serving institutions, as also your tribal colleges and universities, all have to form a partnership to make this happen.
Thank you. Your words continue to ring true for a lot of people, and so thank you for inspiring a number of people on this call, I know. All right, the next one came in that could potentially be for Dr. Fields, but perhaps other people. I'm going to start with Dr. Fields. When nursing faculty are not particularly diverse, as Dr. Bierhaus sort of pointed out in sort of general in nursing, but can also in academic nursing, how can we create a welcoming environment for BIPOC students? I'd sort of love for you to speak to that, and sort of how can all of us create a welcoming environment, given that we are not quite where we should be in terms of diversifying nursing faculty?
So thank you for the question. The nursing profession, academically wise, has been a little bit behind, if you will, even our medical colleagues, in really addressing how do we create these environments by being purposeful and again intentional. So I am the inaugural Associate Dean for Equity and Inclusion in what is now the Ross and Carol Neitz College of Nursing here at Penn State. So one of the ways in which we do this within academia, hire people like myself. And I don't mean hire a diversity specialist. Nursing needed help, and nursing was behind. And you have a lot of these positions being put up, the importance of which are to be able to really work with nursing administrators to be very purposeful about how do we go about recruiting, where do we recruit, how do we partner with what Rear Admiral was just talking about, those historically Black colleges and universities and Hispanic serving institutions, to tap the vast wisdom of those faculty bases if we don't have it at our own. And then working to create welcoming environments, again, very purposefully. Everything from, the pictures on the walls of your nursing school to the nursing history that you teach your students. There's this interesting narrative in nursing history that primarily starts with and ends with a white Eurocentric perspective that centers Florence Nightingale as our be all, but never mentions any other BIPOC nursing luminaries, such as Mary Mahoney, and lots of others. So we need to change the script a little bit, and people need to be better exposed, which is what Ebony said. And I heard you, Ebony. We need to change the script because we can't keep doing the same thing over and over. And as you said, expecting a different outcome. So that's one place where we start, Ashley.
Great, thank you. Dr. Bierhaus, this one's for you. You talked a lot about nursing workforce and the current state of the nursing workforce. Given that this Future of Nursing report is forward-thinking, this is a forward-thinking question. How do we develop a diverse pipeline for the future, especially targeting children and teens to consider nursing as a career?
Well, that's a great question, and I'm glad this was asked. A couple thoughts come to mind. This is based on a study that we did when we, it was a national study where we interviewed parents and teenagers. And ultimately, we were looking at their views of the nursing profession. And there was a question asked of teenagers about who do you look to for advice and who do you trust when you're all kinds of different things that they were, contemplating. I forgot all on the question. One of them was thoughts about your careers. Now, teenagers don't really pay attention to their parents on just about everything, except for careers. That one jumped up. And that was something that was really interesting is they do pay attention to what mom and dad say about careers. And then when we asked the parent or parents about what they knew of nursing, we found that a large percentage did not understand what the employment opportunities were, what their employment security was in terms of economic recessions and when people are out of work and there's nurses there working. They didn't understand the earnings or how much nurses could make, and they didn't understand the opportunities for advancement. So I think the implication of this is that we need to do a good job at educating adults and parents about all of these opportunities in nursing, and knowing that they will have that's one of the few areas that a teenager will listen to. Another finding that we found was when we asked teens, who most influenced your decisions, they said, A, it was their parents, and second, it was interaction with a nurse. And oftentimes that was formed early on when they were children, going to the doctor's office. And then it was nurse practitioners and things like that as well. But when a young person has an interaction with a nurse, and that nurse takes the time to talk about nursing and all the opportunities, this was hugely influential. So I think the implication here is not only do we need to educate parents and adults, but we need to educate our nursing workforce to say, anytime you have an interaction with a younger person, take that opportunity to talk about nursing, inform that person, etc. And so those are sort of research-based ideas that seem to make sense. Beyond that, I don't have other ideas for you. I know there's lots of programs, area health education programs that are going in this direction, but I really want to target on older adults and parents and the nurses themselves.
Great, thank you. Does anyone else have any comments on this topic of how do we get sort of a diverse pipeline before college?
Yeah, I'll make one quick comment, Ashley. We need to get to students earlier. We're waiting too long to talk about nursing as a career. By the time kids get to middle school, I think it's too late. And I still step in front of way too many classrooms where students say things to me like, you can't be a nurse, you're a man, to begin with. And I confront that all the time, let alone being a male of color. So, we gotta develop programs. The National Black Nurses Association, of which I proudly serve as the first vice president, we talk about this in ways in which our, over 100 chapters in 35 plus states, our local chapters, we adopt schools, we go into those schools, we talk about nursing, we show up, and, we can replicate that program. Our president, Dr. Martha Dawson, has a wonderful plan for what she calls the Mini Nurse Academy, which really can be replicated as a model. And it is just that. It is exposing those students earlier and at multiple times. And then serving as those role models.
Ashley, if I could just weigh in one real quick, Sheldon, brought something to my mind. When the Johnson & Johnson campaign for Nursing's Future was launched way back in 2002, we had 5 years in a row of declining enrollments into nursing. It was not a good scene. One of the things that campaign did is they sent hard copy materials to every high school counselor in the country. And this had a dramatic educational piece or stimulant to get more and more people into nursing. I agree with Sheldon. The younger you can start, the better. So as we go forward, maybe we need to go back to something like that, but then also think about other ways to reach younger children that we haven't done before, and start it and just keep that kind of message going all along. Thanks.
Great. Thank you. My next question is for Ms. Hayes.
Ashley,
sorry, Dr.
Other thing that I just wanted to add, because again, as we elevate and look at some of the actual structural barriers that are in place here, I think there's also the conversation of readiness for college, and specifically readiness for a nursing education program. And so to Dr. Field's point, we absolutely have to reach the students earlier to not only expose them to nursing as a career, but also to the rigors, right? You have to be good in math. You have to understand science. These are the foundation and fundamental courses that you have to be successful in order to actually matriculate into a nursing program. So if we've not prepared students at the middle school and high school level to be successful in high level math and sciences and social courses, we're already doing them a disservice. So I think it is starting, but it's also being prepared and aware that once these students do reach college, it's not good enough to dismiss them just because they're struggling. So we have to build these factors in at all levels, and not only not only in the individual level, but understanding the structural communities and practices that they're resulting from.
Thank you. Ms. Haley, this one's for you. So you have been have a really important role in the Camden Coalition. And so this one is, what measures are currently being utilized to encourage and effectively prepare minority nurses for leadership roles? So similar to the ones that you're in, you can speak from a community health and public health perspective on how do we really effectively prepare minority nurses for leadership roles. You seem to have sort of transitioned into one. Dr. Mix, you certainly are in one. We'd love to hear from both of you.
I can speak to the preparation here in Camden at the Coalition. So it starts with mentoring. Mentoring is a big thing. Even just being out in a community, talking, educating. I know it, like even at the local high school that I went to, they have something called exposures in and out. So medical professionals come in and teach about what they do. And they also go out, the students also go out into to different locations to learn about medical professions. And mentoring starts there as well. I feel like at my job, they put me in a lot of uncomfortable situations, but they helped me grow. a lot of uncomfortable situations. I have grown a lot over the years. And just giving people opportunities. The Camden Coalition gives individuals opportunities, some organizations may not, depending on a criminal background history, might not have the ideal resume. That, I believe, is what a probationary period is for. We get 60 days of probation. Give someone a chance and they may excel.
Thank you, Dr. Mix. Anything to add?
Sure. I think for me, it's an interesting story. I actually received a scholarship through the Nursing Workforce Diversity Program, the same program that I just described to you a minute ago. I didn't realize that I received it through that program until I actually was employed by HRSA. So you talk about, the world kind of converging, right? But one of the things that was most important as a part of how Hampton University conducted that program was the mentoring and that true connection with the students. To have someone tap you on the shoulder and say, hey, I know you can do better than what you're doing. It's about time to shape up, right? That's that second semester of freshman year when you finally realize you're free and you start not paying attention to the things that aren't so important. The idea that my faculty member called my mother, I'm in college, right? But it was important because I was at risk of losing a scholarship. And so it was a reminder for me that I'm here not only to learn, but also to meet my goals, to achieve my goals. So I think having mentors, and that was the beginning of mentoring relationships. I've had a mentor through my entire career. I will also say again, the experience of becoming an HBCU grad, the idea that I am learning on a campus that has taken race and ethnicity out of the conversation, right? So that's not a factor of why you're doing better or why you're doing worse here. We're taking it off the table. And so what that does when you get into practice is you realize and you embrace what I'm bringing to that work environment has nothing to do with my race or ethnicity. And so you have to respect me and welcome me for what I'm bringing and not what I look like. And so I think that has allowed me to stand and walk a little bit taller because I came from an environment that allowed me to flourish without having to defend who I am by virtue of race and ethnicity. So I think those are the type of practices, to what Dr. Fields was saying. How can we replicate those type of practices, right? Because that's something that's not unique to the minority serving institutions, right? It's part of the mission and it's of the utmost importance, but it's not unique. And it's not that it can't happen in other places. You just have to be intentional in creating it and enforcing the fact that it needs to happen.
Thank you. So we had a question come in. It's a little bit long, so I'm going to try to shrink it down a little. So there was a 2010 paper in nursing education that was entitled Dismantling Racism in Education. Nursing has and this is a quote from the paper, nursing has a long-standing collective denial and culture of silence in shying away from any racist or discriminatory acknowledgement or discomfort. What steps can we as a profession take from shying away from this racist acknowledgement or discomfort in order to create the meaningful change that the Future of Nursing report recommends?
I'll start. One, let's talk about the fact that the current report centers health equity in a really important way. But health equity, as I said before, cannot be achieved without addressing institutional and structural racism and being intentionally anti-racist. So I'm very clear, just as I was very clear in pointing out that the first report did not start out with a recommendation about the diversity that was necessary in nursing. And if you go back and you look at that videotape of a young Dr. Fields asking a question at the press release of the 210 report, I asked this very question, and so did a lot of my other nursing colleagues. So one, the commission got it right this time in terms of being intentional about including diversity initiatives and markers in a discussion. That was very important. The other thing too is we have to be very honest with ourselves about the fact that at the nursing C-suite, there is a huge lack of diversity. When I mean C-suite, I mean deans, nursing leaders, administrators, CNOs. We have got to be purposeful about succession planning that includes people who are not currently at the table. And I challenge my nursing colleagues that are in those positions now, when you sit around those tables and you look around and you only see reflections of yourself, then you know you need to do something. And everyone can act in whatever capacity they are, but it must be intentional. And nursing has to stop being complicit in the fact that it has not had a very good history of confronting and dealing with its own internal racism. And we have to be, as Dr. Ibram Kendi says, you have to be purposely anti-racist, because you're either a racist or an anti-racist. And by that, and people go, oh, and nursing is good for this. Oh, but I'm a good person. Well, I didn't say that you weren't. But acknowledge the fact that you probably have benefited from racist structures, in the myth of meritocracy. So I'll stop there.
Ashley, this may or may not be on point, but Marshall Chin, one of the members of our NAM committee, recently authored a paper. It was written for physicians. It's in the Journal of Academic Medicine, I believe. And he talked about how you go about as a faculty member, having uncomfortable conversations and putting out all these issues. And when you read that, it's informative, but it makes you realize how uncomfortable people can be and how the lack of support to have those conversations. So I think it's a useful piece to read and understand you're not alone. And here's some advice, here's some help that I think can make faculty members who come into colleges of nursing more comfortable. So it's a side piece. It's not the main, but it's worthwhile. It's a great paper.
Great, thank you. Yes, I feel like Dr. Fields, Dr. Kenya Beard, Dr. Bridget Carter, you all are people that I continue to learn from myself, right? Knowing the field that I'm in, knowing exactly I am the person that sort of represents the majority of nurses, and how I can continue to sort of be an ally, recognize my own bias, the systems in place, and to really try to create as welcoming an environment I can for new students. It's a continuing learning process for me, and I'm grateful to have leaders, like you said, Dr. Field, sort of leaders in that are specialists. You all are specialists in diversity, equity, inclusion. So you all are the ones that can really be helpful for me to make sure I'm reading the right papers. So thank you, Dr. Bierhaus, the right books, the right authors. So thank you for all of the different people you've spoken of. We have had a lot of questions. I am going to finish on this one question because it feels really important as we talk about diversifying the workforce. Dr. Mix, you have spoken a lot to this, but when we talk about encouraging diversity in nursing and in nursing schools, it is hard not to talk about how much our college costs and how much college costs at the university level, and certainly where our community colleges fit into this pipeline. We've talked about BSN being an entry point, which has been challenging for a lot of students. So these are some questions we've gotten, is that many BIPOC students do not even get to apply to nursing school because of inadequate mentorship, first-time college students, and the affordability problem. I'm going to use that, the affordability challenge. Can you all speak to that? Dr. Mix, you've given us some of the grants that we can look to at the federal level. Any other advice?
Absolutely. And I think, in the same time that we're talking about pipeline, we also have to talk about career ladder, right? There are many entry points to the profession of nursing, and we have to be creative in accessing those. Some of the strategic and innovative strategies, where I live in Maryland, we have an Academy of Health Sciences. And what that does is it allows students to be exposed to college level learning through partnership with a community college while they're in high school. And so at the time that they graduate from high school, they also graduate with an associate's degree in health sciences. And so what that does is it gives them a leg up, and it puts them ahead of the curve as they matriculate into a university program. And that's free because that's a high school program. Another option and discussions that I've had are, those that enter into the nursing profession, whether they be LPNs, whether they be associate degree or diploma nurses. At the next point that you're trying to continue your education or move into a specialty, there's nothing written in stone that says that you have to go from an associate's degree to a bachelor's degree to a master's degree. There are programs that if you already have an associate's degree, go ahead and jump right to that master's degree, right? Honestly, at the point right now, it's taking a lot longer than 2 years. Community college, there's no such thing as 2-year community college at this point. Many students are taking 4 years to complete an associate's degree program. So how can we leverage and remove barriers? Again, we're talking systemic. These are not issues that individual students are going to be able to handle. And so I think it goes hand in hand with the cost. I certainly can't address the cost that universities are charging, but I can promote and enhance, the innovative strategies to meet those costs. And I think also those that enter in at, a lower level of education through partnerships with employers who are willing to provide tuition assistance in return for continued service, including the U.S. Public Health Service Commission Corps. So there are a lot of opportunities. And I think to the question, it's also awareness. There are a lot of people who just aren't even aware that these opportunities exist.
So I will address college costs. I'm an academic. So, and I've said this before, we live in a country in which we have a myth of meritocracy. Everyone does not start off with the same opportunities. So let me give you a suggestion I made on another webinar. And it addresses, Ashley, the question that you asked Dr. Bierhaus earlier about the lack of information related to Native American and Indigenous populations. Every single Native American Indigenous student who wants to go to nursing school in this country should go for free. And they should go for free at these large land grant institutions that sit on their ancestral land. Let's call it a little bit of reparations, which I think is very necessary. I actually just read an article this morning that talked about Black millennials who graduate from college and the huge amount of debt. There needs to be purposeful debt. They need to just get rid of the debt. Student loan debt needs to be wiped out because we are losing an entire generation who, because of cost, are finding nursing education prohibitive, especially now as we move to the BSN as the entry and as we move to the DNP as the entry for all advanced practice levels. The cost is important. And then the last thing is students have to be somewhat proactive themselves about finding scholarships. So we just ended the National Black Nursing Association conference in which we gave out over $200,000 in scholarships. And, there's lots of programs out here who do give scholarship money. But as a society, we have to address college costs for all, but specifically for BIPOC populations and Indigenous populations as well.
Thank you. And thank you all for joining us. We are at 3:30 Eastern Time, and I want to thank all of our speakers and presenters. We are offering CEUs through the National League for Nursing, and it will count towards this webinar for 1.5 CEUs, our contact hours. The survey link will be sent by email to you following this webinar, and the slides for this webinar will be available at the National Academy of Medicine website, where you can access the link to this slide that you will see here in a minute. That hopefully pops up. And you can complete the quiz and earn your CEU. The quiz is available until the end of August, until August 30th. The attendance verification code you'll need is 811. So I'm just gonna show you, there it is. So for all of you that can see it, 811 is your verification slide for your CEU. And thank you again for being here. Thank you to our participants. Thank you for the audience. And the panel, you guys were really incredible. Thank you for continuing this journey with us on the Future of Nursing report. And thank you all for submitting comments and questions. Have a great day.